because it's here.
Anh là xong. Just wait a moment.
Okay.
Set up for you. Xong mà em lấy cái này cho bác. Em muốn chuyển cái này qua cái này cho bác.
Thank you. You can put. Sure. Thank you.
Để tiếp tục chương trình, em xin mời quý bác sĩ cùng lắng nghe những chia sẻ của giáo sư, người đã đặt dấu ấn trong lĩnh vực của mình. Xin giới thiệu giáo sư Cesare Paoleschi, là tác giả của cuốn sách Zygoma Implant Surgery, chuyên gia cắt ghép Muscular Forearm, người sáng lập và giám đốc khoa học Iris Compagnia Odontoiatrica, giáo sư Miclo Lorenza ở São Paulo, Brazil, tại viện Devil ở Tây Ban Nha. Và sau đây, giáo sư Cesare Paoleschi sẽ thuyết trình bài thuyết trình của mình về chủ đề kỹ thuật cấy ghép implant Zygoma. So now I would like to invite Professor to present your topic. Yes.
Okay. Thank you. And first of all, I want to say it's a big honor to be here. And I want to thank Mr. Anderson of Bio Leader for the invitation and the J Dental Care for the invitation. So thanks for everything. So today I want to give you my experience and the tricks I could find and some protocol I could develop in these 11 years that now 12 years I'm doing zygomatic implant. This is shortly my experience. And this is my surgical room in one of my clinics. So the point is zygomatic surgery is a risk surgery. It's a difficult surgery. And the question is, should we use it? To use it, we had to have a patient that really need of this surgery, and we have to know how to do this surgery. And how to recognize, to avoid, to recognize, and eventually to manage the complication that we can have. Don't forget, like the other colleague have said before than me, that it has to be the last choice. This treatment, the question is a success treatment for dentists? And I can say the answer is that it is. There are many papers about that. One of the most important, from my point of view, is to decide what is success in zygomatic implant. And Dr. Aparicio made this very interesting paper in which he described which kind of follow-up they do. So it's quite complicated. They remove the prosthesis to see how this prosthesis is made with the protocol of Dr. Aparicio, that is an anatomical protocol in which the implant has to be in the middle of the alveolar process. But most important is that they study the eventually sinusitis and the condition of the gingiva around the implant, and of course, the stability of any single implant. In my clinics, we make things have a follow-up that is a bit more simple. We don't remove the prosthesis, but we check if the prosthesis is stable. We look for eventually sinusitis, and for a problem of the mucosa, and we don't investigate on single implant if we don't have problems. So we make a sort of clinical follow-up, a bit less for research, more clinical. There are many papers. I don't want to describe all these papers because I think it's a bit boring. I want to make you see the clinic. But I will suggest to improve your knowledge about the theory and the papers and the complication and the technique about the zygomatic implant before to begin. So the question is the technique of success? And the answer is yes, it is. And in this beautiful paper has been studied what happened? Has been studied in many ways. The success is always the same thing. I'm sorry, this is in Italian because it's my paper in an Italian review. And so now we know it's a difficult technique, can give complication, but it's a technique that can help a lot the patient. This is, in this paper, I introduce a protocol that I have called ZAPA, that means zygomatic, anatomic, prosthetic approach. That means that we have to do zygomatic implant in the way that we can do a beautiful prosthesis over there. This is my experience up to 23, and how we can see my experience has grown since 2013 and slowly has become a clinical procedure in my clinics. And the other thing that you can read in this slide is that there are few cases of lost zygoma implant, and that the number of not zygoma implant together with zygoma implant are grown on the years. So these are only the patient that have had at least one zygoma implant. And how you can see, my idea has grown, and I just use zygoma implant when I cannot do other things. I always try to use endorsal standard implant together or pterigo implant. So this is a graphic. And this is the way we make our 10-year follow-up. So we don't remove the prosthesis. We check if there is no prosthetic mobility, and we look for rhinosinus status and for the mucosa status. And the result is that we have 4% sinusitis after surgery and some kind of temporary soft tissue problem on the mucosa. So it has helped me to understand that I had to use some protocol to avoid this kind of problems. And I will show you this protocol. It's a protocol in 4 phases and it's in 4 steps, and it's very easy. So, the Zygoma surgery has born because of oncological resection with Dr. Bronnemark. After that, has been introduced as the clinical use for severe maxillary atrophy, or when it was not possible or not in the wish of the patient to use some kind of regenerative or additive technique. So we have a lot of patients that want a solution now. So in these cases, we use zygomatic implant and we don't use regenerative technique. But there is also, in some way, a new indication when you cannot have a stable anchor point with standard implant. So when you have some standard implant, you can put, but not enough to make immediate loading, and you have a patient that has a big request to have immediate loading. So in these cases, I will say the new indication. But zygomatic implant has to be always the last solution. To describe that, 1 year ago, I have counted how many implants I have done in my clinics. And in 2022, I personally have put 4,000 implants, but only 69 Zygoma implants. That was 1.7. And the year after, I have measured again. In the 1923, I have now the help of another guy, and we put 5,300 standard implants, but only 1.6% means 90 Zygoma implants for a year. That means I think I have an interesting experience in zygomatic implant since 11 years. And my suggestion is to improve your knowledge, but to be very careful. You have to use it really in a little amount of your clinic. If you found that you are using 20%, 30% Zygoma implant, you have to ask yourself what is going on. And sorry? It's a laser. I have a little laser. My laser doesn't work. Oh, sorry. Okay, we can. I have a little red laser. Okay, this paper that has been already seen today is the protocol PAXI. That means that first you make posterior, after you make anterior, and after you make tilted, and after eventually you make Zygoma implant. So it's more clear. Posterior, anterior, tilted, Zygoma implant. That means that first you began. It's a bit unusual, I know. At the beginning, I was surprised. I was myself surprised, but it has a sense. You begin with posterior, with a pterigo implant. If you can. Sometimes you cannot. After you go in front, you can put the implant in the piriform rim, I mean a standard way. You can make paranasal, lateral nasal, or you can make it in the anterior nasal spine on the maxilla crest, like you want to call it. And eventually, you use transnasal technique. If you cannot do that, you will use Zygoma implant. And after you go in the premolar area, where you evaluate if you can put tilted implant or transsinus implant. And if you cannot, or if the anchorage is not enough tough, we use Zygoma implant. This is the key. And in my experience, you see, it's going on. This is again a graphic with the number of the patients that have had at least one Zygoma implant. And as you can see, the number is growing, but it's growing much more the use of standard implant or pterigo implant. And it's exactly what I want. And if we see in this way, you see the same thing. So, zygomatic surgery is a great solution. It has a big advantage. Immediate prosthesis rehabilitation are possible even in case of severe atrophy. And that's uncommon. That's a new thing. And it works. It's around 96–98% of success. But there are some disadvantages, and I want to train you to avoid them. First, this technique requires a depth surgical knowledge, learning, and operative organization. You have to have a net of relation with a doctor for the sinus, with a clinical doctor for diabetes. You have to work, it's a deep surgery. You have to have a net. You cannot find a colleague when you have the problem. You have to prepare everything before to avoid the problem. Because the complication of this surgery is different than the complication of dentistry. Are more critical, can happen years after the operation. And there is also, I'm sorry, this is another paper, but this is in Italian, it's a paper. There is also an anatomical question. Why this surgery is difficult? Because the relation between the jaws and the skull in terms of how large and how high is the bone is very different. I know that you are all expert oral surgeon. After you have seen many jaws with different grades of atrophy and different grades of bone density, I will say you have seen everything. You are not anymore surprised. But now you have a relationship, individual, among the face that can be large or little, the sinus that can be pneumatized or not, and the head can be very long or very little, very short, and it changes the surgery. So, the width and the thickness of Zygoma arches is different and individual. The pneumatization, the maxillary sinus, is very different among the people. the vertical dimension is different. The distance between alveolar process and zygoma bone can be very different and can make the surgery different. And everything can be asymmetric. So you have to study, you have to have a tutor, you have to make a workshop, you have to go to a colleague, and the first operation, you have to have a tutor with you, a maxillofacial doctor or expert doctor that can help you. The width, this is our all bone of my clinic, of my cases. And like you see, the width, maybe this is better. No. Okay, much better. The width can be very different. Can be narrow or wide. The thickness can be very different. And this is not a theoretical question, it's a surgical question. And the pneumatization, these are 3 patients of mine, and the pneumatization can be dramatically different. And what's the difference with that? That when you prepare your operation, you don't find the step where you want to put your drill, because it's very, very behind. So the difficulty is different. You can be surprised sometimes. And that's the point. The distance can be very different. This case would be a nice case for the first case. This case is much more difficult because the zygoma is little and this is completely empty. Another thing that I want to stress to you is the vertical dimension. I know that it looks like an anatomical lesson, but it is a clinical lesson. When you have a skull very long, or because of the type of the patient, or because you have, it's not a real atrophic, you have yet alveolar process, you take a bigger risk. Now I will show you. So when this case is a dolichocephalico in Italian, I don't know if it sounds in English, dolichocephalico. It means that the head is very long. That means that the angle to reach the zygoma bone is different than when you have a bradycocephalico, when you have a skull very little. Because the inclination, you can look at me, the inclination is different. If you have a very atrophic case, the inclination of the bone, of the implant is this one. And if you have a very high skull or an appropriate case with a lot of bone that you should not use zygoma implant, but you want to use zygoma implant, in this case, it will be very vertical. And why I want to stress it? Because all the case of penetration in orbital cavity are connected with a long phase or case in which it was present yet bone in the alveolar bone. All the cases, these cases are not mine, thank God, but what they have in common? These skulls are very long, so the angle of the drill is very vertical, so it's very dangerous. So you need, even if you are expert oral surgeon, I'm a dentist too. I had to study a lot, I myself, all the anatomy of the face, of the skull, to manage this kind of surgery. I will show you some of the points. You have to recognize the exit of infraorbital foramina. And we will see when we see the picture of surgery. But why we have it? We need it. Because over the nerve that is more or less horizontal, there is the eye. There is the orbital cavity. So this point are like a line that you can never go up, never. Because one of the difficulties to begin this surgery is to understand where you are. This is a more difficult thing. There is a little nerve that is more or less here. So when you plan your surgery, look at your CBTC to understand where it go out, because it's very variable. And okay, these are the muscles of the lips, but also this, there is a canine muscle and masseter muscle. You have to recognize this structure, and of course, maxillary sinus. Okay, this is the infraorbital foramina, in which you see, when you make surgery, you see some nerve, some fiber that go out. This is one of my cases. Okay, you see that? Do you see this? Yes? Or not? Okay. This is not the foramina. It's a false friend. It's the insertion of canine muscle. That is an insertion that's over the periosteum. But sometimes it's very strong, and the periosteum break, and it looks like foramina, infraorbital foramina. And why it's important to understand that? Because if you think it's the foramina, you make a wrong surgery, because it's your reference. This is the same patient, the same moment, a few minutes after. This is foramina. And what it was, this one, it was the insertion on canine muscle. So if I would have made my surgery thinking that I had to be below this line, my operation will have had a lot of problems, because I had to be below this line. If I stay below this line, I can have problem to put a Zygoma implant, and sure not to. So that's why you need to improve our anatomical level of culture. And of course, we had to do everything about sinus. Why it healthy is not healthy, to make a first diagnosis with CBTC. And if the sinus is not healthy, you cannot operate. So this is the point I was telling before. So like you see, this surgery need that we study a lot anatomy. So to see if the sinus is healthy, you can only understand that with a CBTC. So if you think to do Zygoma implant, you do have to have a CBTC. Do you know what is it? Who knows what is it? Come on. Is it healthy or not? No, it's sinusitis. So this patient cannot be operated until he is healthy. How he can be healthy? With FES, you need a special doctor that makes functional endoscopic sinus surgery. This is a patient of mine that had sinusitis, and we have made this operation, and after some months, we have made the Zygoma implant. Because when you put a Zygoma implant in a not healthy sinus, you will have a severe sinusitis. And I tell that to you because I had it 10 years ago, when I didn't know that. Because it was not so clear in my education curve that this is mandatory. So look at this imaging, and you see how much asymmetric. Sinusitis, healthy, large zygoma, very thin in the same patient. So before to explain how I think you should do Zygoma implant, that I love, I would like to say that I love Zygoma implant, I want to show you what can happen. Some of these problems has been my problem, other from other colleagues. This is not mine, this comes from literature. You can have fracture of the orbital floor, invasion of orbital cavity, orbital fat infection, diplopia as a consequence of that, and the most dramatic retrobulbar hematoma that bring to be blind. You can invite the infratemporal fossa, that is not really a problem, and you can have implant protrusion in the zygoma. Especially in the case of some years ago when the protocol of Nobel Biocare, where I was using Nobel Biocare in that period, was always to be bicortical. So always you had the apex of zygoma implant over the surface. This is the case I make you see. And this is from literature. This is a friend of mine from Israel. When we made the course by Malo around 28, I don't remember, 28 or 2010, I went on studying because I was not self-confident. My friend was very self-confident, and he operated immediately in the clinic alone. And he called me in the night, because after the operation, he understood that he went inside orbital cavity on both sides. And what else we see? That in this case, you didn't need Zygoma implant, probably. So think of this image. This guy is an expert oral surgeon. He's not a stupid person. So to make a mistake with Zygoma implant is easy. So we see some other less dramatic complications. In yellow, you see the complication of Zygoma implant, the special complication. So mucositis, oral antral communication, cutaneous paresthesia, sinusitis, and I think it's a complication, palatal emergence of the implant. It's a mistake. In my protocol, I avoid it. In long term, you can have apical infection symptomatic of the implant. And I know that because I had. And cutaneous fistula, sinusitis, mucositis, periorbital abscess, oroantral nasal fistula. This is a patient of mine. We made a difficult surgery, but everything okay. During the surgery, no bleeding, general anesthesia, so everything okay. But just after the surgery, she had an facial hematoma and hemosinus. So the sinus was full of blood. I didn't load. This thing you see here is ice that we put on the face, but the sinus has been full of blood, and she got sinusitis that didn't pass away with antibiotics. So we had to do a FES, functional endoscopic sinus surgery. So in our surgical room came, what's the name in English? A special doctor to treat the nose. I don't remember the name. Otorinolaringoiatra in Italian. And that had put a little instrument into the nose and opened the communication, the entrance, the communication between sinus and nose, and clean up everything. So this patient could heal, and after, like you see, he had not any more sinusitis, and we could finish our job. And she was very happy after, not very happy in the meanwhile. This case is not mine. It's a case of a colleague of North Italy. And he put 3 Zygoma implant with ball attachment. And any single Zygoma implant began to move. So this guy removed the Zygoma implant, and the patient has had this severe multiple fistula between oral cavity and sinus and oral cavity and nose. A dramatic situation. So I asked a friend of mine to operate, and they moved the medial part of temporal muscle and put the muscle under the mucosa to close these fistulas. So it's a dramatic treatment. These are my cases. These are mucositis. Sometimes it happens. When it happens, I try to understand why. Sometimes it's a mistake. Sometimes it's a smoker. Sometimes I don't understand why. You see, in this case, the mucositis happened suddenly 7 years after surgery. Why? I don't know. I can say that she is a smoker, maybe. But I'm very tolerant with smoking because I smoke. So. This is another case of mucositis. You know what I can do? Yeah? Okay? Okay. Why? No, okay. It's a go. Okay. No. Okay, we go ahead. So, but I want to show you this case. It's the same case after some years. She had this patient. She had this mucositis that slowly was growing. Thank you. Was growing and growing. And the last 6 months ago, suddenly, she had an oral fistula, a severe oral fistula. This is a patient of mine of 11 years ago, but at that period, I was sharing my cases because I needed a tutor with a maxillofacial surgeon. So I made this side and he made this side. But anyway, it's my patient. I want to make you see is, you see this big window, no? So I always didn't like it. So my technique that I will show you soon in some slides is what I did already 12 years ago. That means to make a sort of tunnel and not to open a window. I know that if you open a window, you see better. But we are all dentists, and we have had root filling of the 7th superior molar, the 2nd superior molar, from a little 3-4 millimeter window. So I think that we can understand everything with this kind of anthrotomia instead of to make a big window. Because if you have a mucositis, if the mucositis reach this area, you have the right that everything can collapse. And what happened here? And here is completely collapsed. So don't do big windows, because you don't have problem now, you don't have problem in 5 years, maybe you don't have problem in 8 years, but first or later you can have a problem. And this is the picture during the operation of 2013, when I make the operation. So like I told you, this is my technique, and this big window is the technique of my colleague. That up to date is the most common technique in the hand of a lot of surgeons. And I suggest you not to do that. This is another my case, implant protrusion. So we had this fistula in a very elegant lady from Florence. And it was exactly what Nobel Biocare was suggesting 12 years ago. But it is a mistake. And now we know it's a mistake. So a friend of mine, a plastic surgeon, has made that in our surgical room. We make a sort of apicectomy. We cut away the apex of the implant. And I was very worried about that, but my friend is very talented, and after 2 years, you see nothing. So what I mean that you need a net of relation around you if you want to see surgery all the weeks or once a month. You need to manage different things. And of course, you can have some prosthetic fracture or loosening or hyperplasia of the mucosa. But this is of another colleague of mine. And it happened after 13 years. The implant broke. So why I make you see all these things? Because I want to say you, these implants are fantastic. I love these implants. Use them in the correct way because they can give you a lot of problems if you make some kind of mistake. Sinusitis. This patient was healthy after she got sinusitis, and after we made fast therapy, she became healthy again. I follow any case I have operated. I don't do operation in another clinic. I just work in my house. So I follow all the cases I do. That's why I'm so much involved in complications, because many people make operations around the world, and after nobody follow the patient. I follow all the patients I operate. So this is the two very interesting papers about sinusitis and Zygoma implant. And what they say, I make it very short, is depends how you operate. Depending how you operate, you can have sinusitis or not. If you are more extra sinus, it's better. If you don't break the sinus membrane, it's better. If your surgery is gentle, it's better. These are cases from other dentists. It's not my case. But these are not complications. These are mistakes. Because it has no sense to put ball attachment over Zygoma implant, because the mobile denture will make a pressure on the mucosa, and you will have a mucositis with the infection. And first or later, you will lose this implant. It's not a complication. It's a mistake. Or I like to put implant a bit extra sinus, but not too much. In this case, the implant were too much extra sinus. The other thing I want to, so up to date. Zygoma implant works. Zygoma implants are dangerous. One of the things we have to learn is biomechanical schemes that are a bit different. You can have an area which you have enough bone to make what we call hybrido. I mean, standard implant in front and Zygoma back. Or you can have a minimum level of bone and you need to make a quad. This is what Paul Malo taught me many years ago. Now the things are more complicated, but what I want to show you, that even if you put only 2 Zygoma implants in the distal area, you have to mark 2 lines. 2 lines. Because in the future, you can lose this implant. So you need the room to put the second mesial Zygoma implant. And this technique has been developed by the concept of all-on-4 of Paul Malot. But now, I made this joke, I wrote it in my book. We are over the all-on-4, and we need all more, making a joke with English sentence. Because it's much better, when it's possible, to use standard implant to have a load more balanced in the jaw. So, in the experience of the group that made PASI protocol, so Horst Cloud, Gonzalez, and so on, that the colleague has said before, they call it more or less in the same way, all on X. That means that you use PASI protocol to avoid Zygoma implant, but when you need, you put a fantastic Zygoma implant, you won't have problem. So let's see if this is the paper, and there is also the book that the colleague has shown you before. And this is a scheme I want to recommend you to follow. So first, you go posterior. And if you can, you put pterigo implant. Second step, this part we see after. Second step, you go in the anterior. You can put parallel, paranasal, lateral nasal, maxillary crest, and transnasal. And after, you put in the premolar area, and you try to put tilted or transnasal, but transsinus implant. And if you cannot, you put Zygoma implant. This is the PASI scheme. I have made a little variation. I modified in my clinic this thing, because when I cannot put pterigo implant because the tuberosity is too narrow, or because I don't succeed in reaching the fusion of pterigo bone and pyramidal process of palatal bone. If I don't use pterigo implant, and I will have to use Zygoma implant, anterior, I suggest you to use 4 implant, not 2. So anyway, to go out all-on-4 scheme. So if you need to put 2 Zygoma implant and you could not put pterigo, try to put 4 standard in front and not 2. Because you have much less problem instability of prosthesis. And this again, the scheme. And so let's see if it's true. This is a lot of cases, just a summary. So in this case, we plan to do a PASI protocol. I mean, we were ready to put Zygoma, we were ready to put everything. We could not put pterigo implant, also because of that tooth. So we put 2 transsinus implant and 4 implant anterior. In this other case, always with immediate loading, we have put pterigo implant, transsinus implant, maxillary crest implant, and lateral nasal implant. But not Zygoma, because all these implants were had a good anchorage. In this case, we put, you can see 2 implants in the maxillary crest that they don't touch each other. They stay on 2 different planes. One is more vestibular and one is more palatal. But this lady had to do Zygoma implant because it was very soft tissue and very narrow, and I could not reach to put pterigo implant to put other implants, so other implant. So it's a typical all-on-4 scheme, and it's very well working. It's not a mistake. But this is the scheme I prefer. When I can, I put pterigo implant, anterior implant, and Zygoma implant if I cannot put tilted implant with a good anchorage. In this case, we made the nasal implant, and we see here how is the relation with the bone. 2 pterigo implant and 2 Zygoma implant. In this case, instead, I could not put the pterigo implant, so I had to use the Zygoma implant because of the pneumatization of the sinus, but I tried and I succeeded to put 4 implants, so that the stability of the prosthesis is very good. In this case, the only thing I could do has been to do the quad. I could not put anything in pterigo implant as there was 0 bone in the front. And again, this is another case in which I put 4 Zygoma, but I could reach to put 2 pterigo. That is much better. And of course, all these cases can be asymmetric. So on a side, I had to put a Zygoma. On the other side, I succeed putting a tilted implant with a good anchorage. But these schemes that we need to know how biomechanical they work are not so interesting for the patient. The patient wants that the implant prosthetic connection will be compatible with ideal prosthesis. We have the duty to think about that. So we can have an ideal exit, that means really on the crown of the tooth. We can have an adequate exit, that means that your Toronto, your bridge, will be not modified. Or you can have a compromise, where you modify your Toronto to reach the prosthetic connection. And I had to confess you that in the anterior area of atrophic maxilla, often you have to accept it, because the resorption will be from anterior to posterior. And so if you don't make regeneration, you have a physical limit. But you won't have problem here a lot, because you are very far away from the position on the tongue. The most important thing is where they exit in premolar and pterigo area, where the tongue can have an obstacle and can have discomfort. And of course, depending which kind of scheme, the loading has certain rule. I mean, you have to think that when you put implant, if it will be a quad, you have to reduce the loading in the anterior area because the anchorage is here. So the extension is in front. In a few minutes, we begin with blood, and you will be more interested. But just the last thing. This is the Zaga classification. And you know that type 0, 1, 2, 3, 4. This classification has an anatomical principle. Aparicio says, put the one of the point of the Zygoma implant in the alveolar bone, in the central alveolar bone, and the other in the zygoma. And depending of the concavity of the maxilla, it will be one of these types. Well, I don't agree with that. And first, I want my prosthetic connection not going out where the alveolar process today is, because in the atrophic maxilla, the alveolar bone, the few alveolar bone, can be very medial, can be too much close to the tongue, can invade the palatal area. So I think we have to have the connection in relation not with the anatomic only, but also where the prosthesis is. So I suggest you first to study the ideal prosthesis for the patient, after to understand where the prosthetical connection has to go out, and to put the implant so that prosthetic connection will go out in that point. It's not magic, it's a protocol. The second thing, I want to avoid mucositis. So I suggest you to think the Zygoma implant as much as you can. How much is? When you meet the sinus membrane on the nasal membrane, you have to stop. So I always try to think the Zygoma implant. And so I made this, and I wanted to give a name: zygomatic, anatomical, prosthetic approach. I want to know where is the tooth of the ideal prosthesis. We are dentists. The patient comes to us just for one reason: to have nice prosthesis. They are not really interested in surgery. So I put implants, studying very well where will be the prosthesis. And if it's very atrophic, and the prosthesis is very lateral, I will put the head of my Zygoma implant a bit more lateral, giving the room for the abutment to bend with a multi-unit abutment, and to have a correct exit where is the prosthesis, without invading the palatal area. So I study before where will be the prosthesis, and after I leave the room individually at that patient, depending what is the prosthesis, the future prosthesis in that patient. This is my protocol, the meaning of my protocol. And to reach it, I asked J Dental Care to product this tool. This tool is called Zappa tool from my protocol and can help you for zygomatic surgery, but also for any surgery, for three things. First thing, we can understand how much I have to leave of room to put the MUA, so the multi-unit abutment, so that the prosthetic exit will be compatible with our prosthetic project. Second, it's going worse and worse. Second, we can decide which inclination, 17, 30, 45, 52, and 60 grades. But the third thing that always my friend forget, that you can make a sort of fine-tuning, in which you move a bit, the third movement, you move a bit, because the Zygoma implant has an hexagon. So has 30 grades between the possibility. And maybe the correct position in the middle. You understand what I mean? So you have this implant, and here you have the implant. Here you have the MUA. But if the implant is 15 grade so, the MUA will be so, and it's not good. So before to finish the surgery, with this instrument, with this tool, you can move a bit so that you can understand where the prosthetic connection will be in the best position. That means, in this case, this one. Because otherwise, could be 10, 15 grades too much in front or too much posterior. You will see in the picture soon. Okay, and this is our duty. If you do that, you cannot understand from the prosthesis, these are temporary prosthesis, you cannot understand if this one is Zygoma, standard implant. You don't understand. You have the same goal. So, we have a little of blood now. So, always mark 2 lines. You have to track the direction and to mark the 2 lines, even if you put only a distal Zygoma implant, like in this case. Why we had to do that? I mean, this is my experience. Now I will show you. So this is another case. Always 2 lines, always. And if you have the need of that, you can put the Bisha fat pad so that you can protect the surface of the implant and can help to close the eventual communication. You see how these connections are parallel. They are so parallel because I have used this Zappa tool. So for any multi-unit abutment, I have moved a bit the implant until, and I have showed the correct multi-unit abutment until I reach this result. And how I could think that this result will be correct for the prosthesis? Because I use this surgical stent. This is a copy of the prosthetic project. So what I do, I work in freehand surgery. I prefer to work in freehand surgery, but I always make a surgery that is prosthetic guided. And this is, sorry for the quality of the picture, they are very old. This is why I did it. Why is I'm stressing that so much? This is a patient I operated in 2012. I put all on 4, and immediately he lost 1 implant. In 2013, I was making all on 4 since few years, 3-4 years. So when I lost this implant, that I didn't lose, I lost during the healing period. I thought that all on 4 was shit, and I put sinus lift, thinking, okay, better sinus lift. This new thing I don't like. And I lost also the implant with sinus lift, and I also lost the other. So first I put a Zygoma implant, and after I lost also the implant with sinus lift. So at the end, I had only this Zygoma implant. But in that period, I was not making the 2 lines. I was making like Nobel Biocare was teaching and how was the guide of Nobel Biocare. So I put this is from the book of the Zygoma implant technique of the Nobel Biocare. So I put exactly the implant in the best place of the Zygoma arch, also because I had 3 other implants. So I thought, okay. And I made exactly what they teach me, but what they teach me was wrong. And so, at the end, I had only 1 implant. And I could not put other implant. So, in 2016, I could put 2 implants Nobel Biocare on this side, and it was not possible to put anything other here. But I like to say, I don't know, it's a joke. I don't know if God exists, but after I see that case, I think if it exists, he loves dentists. Because it's a joke, of course. Because we had no problems. This patient stayed with 3 Zygoma implants with no problems. I don't know why. And after a couple of years, asked us to do that in porcelain. And it has gone with no problem. Absolutely mysterious. But some years after, I had this patient in 2020. And she came in visit in this way. And she had 3 implants to put away, a disaster in the lower jaw. And this implant is a megagen that looks like good, a short implant. And so I thought, I should trust a short implant. I always don't trust short implants in the maxilla, but it was since some years. So I said, okay, I trust. But when I made the surgery, projecting, managing to leave the implant in position, I anyway made 2 lines the year after, when I had to load, I lost this implant. But I have made 2 lines 1 year before. So I simply put a mesial Zygoma implant with no problem because I have marked 2 lines 1 year before, even if I thought not to put any more Zygoma implants. And so this is the result with the quad to pterigo implant, and we use what she had in the lavage. So this is the protocol I was speaking to you. Sorry, it's in Italian, but it's explained in the book, and the book is in English. And it's an operative step in 4 steps. First, the input. We select a patient with severe atrophic maxilla. We check the situation. We check the CBTC. And eventually, we make the FES. If we don't have the diagnosis, we don't operate. After that, we make planning. Not surgical planning. We make the prosthetic planning because the prosthesis is the only reason for which the patient came to us. So we make a mock-up, we make this is analogic flow. After we see also the digital. This is my traditional analogy. We make all the tests, we ask the patient if she likes it, and after we make the surgical stent that will drive our surgery. So after that, we make surgery project. So we study the patient anatomy, how wide, how thin, how is the distance, which kind of difficulty we have. And to do that, I prefer, I prefer to use a stereolithography, not only the PC. I prefer to study in the hand. After that, it begins the operation. And the surgery, we make a PATSI protocol. After the operation, impression, stent solidarization, and if it's possible, immediate loading. And this is the output. This is our protocol. So, the input, we study the sinus, we study the situation, has adequate systemic health condition, yes, no. So, no, rheumatologist, doctor. Otology, healthy, otorhinolaryngologist, eventually fast surgery. And aesthetic evaluation. Why I put these pictures? Because if the patient asks you that want to be so, this patient asks you, I was so, doctor, make me in this way. I always answer, if I could do that, I will be in TV. I will be in the news. So reduce the wish of the patient. The patient has to know that no human being will be able to make hair in that way. But that you had to say before operation, not after operation. So, prosthetic project, surgical process. We make, if the prosthesis is correct, we make a little adjustment. Otherwise, we make a new one, and we work until she's happy, and after we make the stent. After we make surgical project, so we study the combi, we study the stereolithography, we make a project in the computer, and we prepare ourselves to make the operation. And again, we try to avoid, and this is our guide. And this is how I do. First 2 lines. This is the lady, exactly her. I use this little bar. I make this tunnel. I use the first burr to make the first level. And after I move this instrument to go a bit deeper until I found the sinus membrane. And I prepare with a drill and I put the implant. And now I use the Zappa tool to reach it. If you do that, when you will do the prosthesis, you will not have problem because I can change everything now. I can make the head of the Zygoma implant more lateral. I can move some grades. I can change the multi-unit abutment. I can do everything. You want to see the surgery? Maybe I'll try to be a bit more fast because... Okay. This is the so we begin with the opening. This patient has been operated in a general anesthesia. And I like to use this octagate to help the lips not to be damaged. I try to go a bit more faster. Okay, you see, this one, again, is a canine muscle. It's not a foramen. Now I reach the nasal cavity. This is foramina, you see, and I mark. But this is a protocol. If you see 100 of my operation, you will recognize the protocol. This is the nasal floor. I want to see what is the nasal floor because I will try not to use the Zygoma implant. I want to see if I can avoid. And now I understand I have to use Zygoma, so I'm making this space here, laterally to the Zygoma. So we open in the posterior area to put pterygo implant. We make alveolo plastic to have a correct surface where the Toronto can have a base. Okay. We mark the two lines. In this case, we put two Zygoma, but I will anyway mark two lines. Also on the other side, and I begin with this instrument. You see, I don't do a big window. I do a very little window, so big as the Zygoma implant. I don't need more. I save the sinus membrane. I make my evaluation, and after, I make the tunnel. You see? And I sunk a bit to avoid mucositis. And I put the implant. But now I use my Zappa tool to understand how many grades I had to move it. And I try my surgical stent. That's the point. That's why I don't appreciate the Zaga protocol, because I need to know where will be the teeth. I think our surgery has to be prosthetic driven, always. So this surgery is a freehand prosthetic driven surgery. So again, I make the same operation so that the prosthetic connection will be perfect for the prosthesis I have already studied before operation. And you see, this result is not for case. This result is due to the protocol. And after, we put pterygo implants. And you see, again, we are guided by the prosthesis project. Because of these implants are so long on the surface, I decided to move the Bisha fat pad. With some resorbable stitch. So we go ahead. And we made immediate loading. Sometimes I use piezo surgery. Now, very seldom. For almost 10 years, I have used for any single case. But the new instrument of JD, the new burner with, what's the name of that? The first, not the drill, the one before, what's the name? It's fantastic. So now, really, I don't use because it's very little and you can make a good work. But before, to avoid to use, because the original technique was to use a little hole and after to go with the drill. And if the project was wrong and the arc of the Zygoma was narrow, you would have destroyed everything. So in the difficult cases and before, in any cases, before they, JD now has this instrument. Since has this instrument, I don't use anymore a lot of piezo surgery. But anyway, piezo surgery can be very useful at the beginning because it's very gentle. Now I want to show you one case in which I made a mistake. And this is, I made my lines, another case. I made my tunnel, I begin my tunnel, but it was very narrow, and I went in infraforamina cavity. So I made a mistake. But using the new drill of JD or using this gentle instrument, that piezo surgery, you can go back. And so I modified the inclination after I check everything. I use the drill and I put the implant. But now you can do with the new drill that is a fantastic drill. Okay, this is this operation, but I don't know how much time I have. I think it's too late for you. Okay, so we don't see it. It's a piezo surgery. Maybe we will see another time. So if everything is okay, we make impression. We make solidarization with surgical stent to get immediate loading. And if the torque is more than 40 for any implant, we can make immediate loading. But also to check the primary stability, we have to check the summation of all the stability. Because if one implant is 30, but the other three are 80, of course, we can make immediate loading. And this is when we make solidarization of the surgical stent. And this is the lady in which we have made our surgery in the upper and in the lower jaw in the same day. what I want to show you that the prosthetic connections are perfect. Are perfect because of the protocol. And this is our follow-up after 1 year. And we made the rhino-sinus status, that's perfect. Implant stability report, I mean prosthetic stability. No, we don't do implant stability report if we don't have problems. And soft tissue status that is perfect. And this is another case where I will make it a bit short. Okay. This is a situation, you see. You have a severe atrophic situation. And we have a good zeta point. So we will see. So during the operation, we tried, as I think, to do transnasal implant. And sometimes I like to make the first knock from outside to avoid force movement. Okay, I'll go a bit more fast. Okay. Here I'm using piezo surgery to be more gentle. Okay. It had to be very gentle surgery because you had to study before the distance between the nasolacrimal duct and the base of inferior turbinate. So they call it the zeta point. So you had to study very well before, and after you had to be very gentle because this bone is very fragile. You see there is some fracture, but the stability will be very brilliant just on the apex. You see, we have 80 Newton of stability. And after, we make the Zygoma. And again, you will see the same thing. I mean, any case is very individual, but the protocol will drive you through all this jungle of situations. Here I'm using the piezo surgery because it was before the production of that special instrument I told you before. You see I make my tunnel. I try the surgical stand. And after I use the drill, I measure how much bone I have in contact with the implant. I put my implant, that is almost 80, and again I use Zappa tool to have a perfect prosthetic connection. Okay, and now you see, we check the situation also with the transnasal. I use the Zappa tool anyway to have perfect multi-unit abutment, and the same with the pterigo implant. And I think I cannot imagine to work without this instrument. Unfortunately, I don't have money from JD when they sell it. And this is the panoramic of the maxilla. So we make the solidarization in an analogic procedure, the impression, and we check if the implant, because these are special implants, so we check if the implants are, all the implants are in the correct place like we wanted. So we check the pterigo implant, with transnasal implant, the Zygoma implant, if everything is okay. This is the panoramic X-ray. This is the temporary prosthesis that we made the same day. This is the CAD-CAM procedure, and this is the finish denture. And before to leave you, I want to make you the last slide, how now we are beginning to do. It's not a conventional treatment. Now we do this kind of cases, any 2-3 cases, any 4 cases we do, with digital rehabilitation, but according to Zappa protocol. This lady came in this situation with, no, this man, sorry, with some implant with infection. So we check if we could make Zygoma implant or what else, because he had a definitive awful prosthesis. So I had to destroy it to check the situation. So I prepared everything so I could do what I needed. You see the situation? And the awful prosthesis, definitive prosthesis, was also broken. So we made a digital project in this case. And we try to imagine a new smile. I will be very fast because it's not the goal of today. And anyway, we have made a sort of surgical stent. This is not an analogic copy, but we print it. And even in this case, this has been made in local anesthesia in the clinic, not in surgical room. But anyway, we use the Zappa tool so we could check the surgical stent, and we could check the occlusion to choose what is better. After the operation, we check everything. I put only one Zygoma implant. I extract 2 or 3 implants. I kept the other implant, and I put just one. This one is a new one. And I have no chance to do pterigo implant. I have no chance to do anything else than to put this implant. And I was very worried about this case because I knew that it was very vertical. Let's go back. You see how vertical is the implant? Here there is the eye. When you have a long face and it's vertical and the angle is close to the orbital cavity, be very careful. I was very worried. Because, and I didn't do bicortical. I stopped before. Because I had enough bone. I stopped before because if I would have gone up, I was not so sure where I could go. So this is the situation after the surgery. So I put away the implant that were here, and I put a Zygoma. I use the others, in which I change the abutment. And the same day, we primed the denture we had. We have made the project, the digital project. At the same day, we have primed it. That's fantastic. He was very happy. This is the temporary. And after a month, we have made a revaluation, aesthetic revaluation. We made a little, modified a little our project, and we made the definitive prosthesis, CAD-CAM with zirconia. And you see the Zygoma implant is perfectly in the crown. Who could say if this one is a Zygoma implant or conventional implant or pterigo implant or sinus lift procedures? You cannot understand because all the protocol has driven you to have it. And he's more happy than before even. So, I almost have finished. What you need? You need to study a lot, like when you were in university. And to have a knowledge very extensive of the anatomical structure and of the treatment of the complication. Of course, you have already had to have a real experience in oral implant or in oral surgery. You cannot go away from university and begin with that. But in dental science, we are used to study a weekend, and after we feel ourselves self-confident and ready. I remember very well. We study how to do a filling, aesthetic filling in the front anterior area, and the Monday morning we make aesthetic filling. We don't need all other things. We study how to use endodontic therapy, some new thing, like a microscopy or something like that, and the Monday morning we can use it. But with the Zygoma implant, the curve of learning is more similar to the curve of learning of medicine. So when our colleague, the doctor, has to learn how to do an operation, they don't do a weekend course. They stay 1 year in the hospital. And they have adequate training, and they have a tutor. At the beginning, the tutor work. After the student begins to work, and after the tutor only watch the young doctor to work. That's what happened to medicine doctors. And I think this therapy has to be learned in this way. You need an organization, a net of relation. If you have a sinusitis, if you have a problem with the plastic surgery, you already have to have a relation with these people. It's not something you can do alone in your clinic. And I think you need a protocol. I think my protocol can be very useful for that. So, I have finished. And this is, if you make a picture here, you will be in contact with my Instagram. And it's my private Instagram, so I'm ready to answer to any question, even in the future. This is my book. And in Italy, once a month, we make live surgery, where the doctor comes in surgical room, and before we discuss, and after they see what is going on. So, I have finished.
Thanks, Professor, for your presentation. And please wait a little. If Doctor, they have some question for you.
Please.
Yes. Vừa rồi là phần trình bày của giáo sư Cesare Paoleschi về chủ đề kỹ thuật cấy ghép Implant Zygoma. Thì kính mời quý bác sĩ có câu hỏi nào dành cho bác thì xin phát biểu ạ. Dạ, quý bác sĩ có câu hỏi nào dành cho bác không ạ?
Okay, everybody has understood everything.
Yes, I show one hand. Yes, just wait. Dạ, chào bác ạ. Xin mời bác.
Xin giáo sư cho biết là trong các cái phẫu thuật của xương gò má ấy, thì mình có luôn mở vạt để nhìn thấy đánh dấu cái thần kinh dưới ống mắt không ạ?
Sorry. Yes, I always mark the infraorbital foramina because I want to be sure. Thank you.
Vâng, cảm ơn giáo sư ạ. Cái này là em quan tâm bởi vì là trước một cái kỹ thuật khó thì cái điều mình quan tâm nhất đó là biến chứng và phải tránh được biến chứng khi làm.
Yeah.
Yes. One more. Yes.
Thank you, Doctor, your presentation. Regarding the zygomatic implants, there are two sizes. One is 3.9 and one is 4.2. Any special preference and why?
It's a very good question. Originally, the J Dental Care had a 4.3 Zygoma implant that I have used. After a while, has made the 3.9 Zygoma implant, and have used both. Now, I always use 3.9 Zygoma implant, in the wish that if I don't have enough anchorage, enough stability, I can use a wider implant. So I can use the 4.3. And I asked to the company to make a 4.3 implant different. I think it will come out soon. That give us a big anchorage when you have problem with 3.9. Because sometimes, even if you prepare, you under-prepare, you prepare a little, if the bone had low quality, you can have not enough anchorage. One of the cases I show today, we didn't do immediate loading. So the answer is always 3.9.
Yes, thank you for your answer. Continue one more, Dr. Wang.
Thưa giáo sư, thì cho thấy ông làm Implant Zygoma cũng khá nhiều năm á. Thì theo ông thì trong quá trình theo dõi cái Implant Zygoma thì ông có thấy cái trường hợp nào nó bị bật cổ ra khỏi cái vùng cổ của Implant Zygoma không? Và nếu như có trường hợp đó thì cái giải pháp của ông là gì?
Sorry, I didn't understand the answer, the question. You mean the apex? I don't know if I have understood the question. When the implant don't move, it's stable. And eventually, if you lose the Zygoma implant, you have to screw away. Even if you have a failure, the failure is because of there is a length of the implant into the Zygoma. In the 10 cases I put away, I had a failure, I had to unscrew. I don't know if that was... You mean disturbing the tongue? Yes, I had a mucositis. In some cases, I had a mucositis, and the cases more severe that I show you, I had to unscrew the implant, and we are making complex therapy. I have used I have made a buccinator flap that is a portion of buccinator muscle, and I had to take it to move to seal the fistula after I put away the Zygoma. Did I answer? Okay.
Xin hỏi là còn bác nào cũng đặt câu hỏi thêm cho giáo sư không ạ? Nếu như không còn câu hỏi nào thì em xin tiếp tục chương trình với phần bốc thăm trúng thưởng ạ.
Okay. Gum on.
Gum on. Yes, so good. Tiếp tục chương trình sẽ là phần rất là quan trọng, không thể thiếu trong mỗi cuộc hội thảo, đó là phần bốc thăm trúng thưởng ạ. Và